Welcome everyone, and thank you for joining us for our June My Macular and Me webinar. For those who don't know me, my name's Ed Holloway, and I'm very proud to be the Chief Executive of the Macular Society. And tonight we're really pleased to be joined by Dr. Jasleen Jolly, who's a Senior Clinical Research Fellow and Optometrist in the University of Oxford's Nuffield Department of Clinical Neurosciences.
Not anymore.
No. Sorry, is this a slightly out of date bio? Well, I think the rest of this is correct because this is historical, and then you can correct us on where you are now. But having graduated as an optometrist from Cardiff University and with a career primarily in hospital care and experience in research in Australia, she completed her MSc in Investigative Ophthalmology and Vision Science in 2011 from the University of Manchester. Dr. Jolly has a background in both clinical practice and academic research, with a particular interest in visual perception and the lived experience of sight loss. Her work focuses on neuro-ophthalmology and visual hallucinations, with a strong emphasis on patient-centered research. And in tonight's session, Dr. Jolly will be sharing insights from her research into Charles Bonnet syndrome. Charles Bonnet syndrome is thought to affect up to half of people with macular degeneration at some point, and it's a condition where people with sight loss experience vivid visual hallucinations. The hallucinations appear to exist in the real world, and people have reported seeing anything from landscape gardens or vistas to animals, people, and processions of miniature costume figures. The hallucinations are often seen in more vivid detail than real life. They come and go unannounced and can last for just a few seconds or as long as a day or more. Despite being fairly common, it's often misunderstood or underreported, and Dr. Jolly's research aims to understand how and why these hallucinations occur, what they can tell us about brain function, and how people affected can best be supported. She'll discuss what we currently know about Charles Bonnet syndrome, how it affects those with macular degeneration, and the latest findings from her work with people living with the condition. There'll be time for questions at the end, so please do feel to pop those in the chat during the session. So apologies for not getting your institution correctly, or current institution, but now I'll hand over to Dr. Jasleen Jolly. Thank you very much.
Thanks, Ed. Yeah, sorry, I should have sent you my up-to-date bio. But thanks very much for the introduction. I have got a few slides, but don't worry too much about them because they're more as an aid memoir for me. So there's not a huge amount on them. So let's get them loaded up. There we go. If someone can just give me a thumbs up to say that they're showing properly.
That they are showing correctly.
Lovely, thank you very much. So I'm now an associate professor in multidisciplinary vision research at Jolly Vision Science, which is based in the UK, and I have an honorary post at the University of Melbourne. So what is Charles Bonnet syndrome? Well, it's the presence of secondary hallucinations that occur after you get some level of vision loss. So this little graphic was produced by one of my patients who's also an artist, and it just shows a robot crossing a park. So this was created based on a report of one of the hallucinations that another patient reported. So and it shows how the background is quite dark, so the vision in the background is not great, but the actual robot is super clear and bright. So it's the juxtaposition of the hallucination versus the background. So the Charles Bonnet syndrome is like the visual equivalent of phantom limb syndrome. Or so, you know, when someone loses a limb, they can still feel it. Many people have heard of that. Or tinnitus is the hearing equivalent. And in all of these cases, you lose some sensory input into the brain, and then the brain tries to fill in the information. So I'll talk a bit more about that. But there are key questions about what's going on. about that we need to know. One is the prevalence. So how common is it? Two is the mechanism, what's causing it, and three is treatment. So prevalence studies are really, really hard to do because you need to sample everybody in a fixed population at a fixed point in time in order to know the exact percentage of the people who get Charles Bonnet syndrome. And that's actually really hard to do, to capture. So we know it's higher than what's been reported because most of the prevalence that has been reported has been based on little case series. And that doesn't really give you a prevalence because it's a skewed population. And I've tried doing some prevalence studies, but invariably people get missed asking the question, and then you don't have an accurate percentage. But prevalence has been estimated anywhere between 10 and 60% of people. Now, I've always asked everyone who I see for a low vision. So my own personal feeling is it's probably closer towards the 50%-ish mark. But there are lots of factors that can affect the prevalence. So it probably changes over time. Like during lockdown, it was reported that isolation and stress can increase the prevalence. I'm going to go through a number of myths that have developed over the years. So myth number one, Charles Bonnet only occurs in the elderly. No, absolutely not. So work published in the last few years shows it can even occur in children. It can actually occur in any age as a result of any disease and any severity. So a lot of the earlier work was done exclusively on people with macular degeneration, which is where this myth has come from. So people with juvenile macular degeneration, people with optic neuritis, literally any eye disease at any causing any kind of ocular pathology, whether it's in the eye, the brain, or anywhere in between, can cause Charles Bonnet syndrome. Esme's Umbrella is a charity dedicated to Charles Bonnet syndrome, and they've now got a page dedicated to talking to children about Charles Bonnet syndrome. So M is the helpful, friendly monster that you can use to talk to children, and it might not be just children who are experienced Charles Bonnet syndrome, but if you have relatives that you want to explain what you're experiencing, then this is a nice way of doing it. CBS has a low prevalence, so I've already talked about this, that we don't actually fully know, but I actually do think it's more towards the higher end. But people don't generally volunteer the information because people are afraid of being thought to be going crazy. And not enough practitioners have enough awareness or actively screen for it, and we're trying to change that with all the education activities that we're doing. So just last week I presented to an international audience, sorry. Please bear with me, I'm just recovering from a chest infection. So yeah, last week presented to an international audience, and I'm doing that same again in September. So we're trying to really hard to raise awareness about CBS and encouraging more people to screen all their low vision patients. So we can buff that myth that it does not have a low prevalence. Myth number 3, CBS only occurs with significant vision loss. So the previous number that used to get bandied about is that you'd have to have 60% of vision loss to get CBS. Well, how do you grade vision loss? Because some people have peripheral vision loss, some people have central vision loss, some people have acuity loss, some people have visual field loss, some people have color vision loss, some people have contrast sensitivity loss. So, you know, how do you even grade percentage loss, for one? To me, that makes absolutely no sense to look at it in that way. But also, we've shown, as have others, that actually that's not true, because you can have loss of vision in one eye only. So we published a case study where someone with cancer in one eye, and they had one eye removed and the other eye was 100% healthy and still had hallucinations. And then there was another set of case series that presented at a conference where they had temporary reduction in one eye due to retinal problems, so floaters or retinal detachment, and still had Charles Bonnet syndrome. So actually, it's not the degree of vision loss that matters, it's the fact that you've just got some vision loss that can cause that the trigger and changes in the pathway to the brain. So the brain senses a change in the visual input, and that seems to be enough to trigger in some people it causes some kind of imbalance that then leads on to having hallucinations. Now, we don't know exactly what that cascade is. So the reason why our vision as humans is so quick is that our vision is modified. So our vision doesn't just consist of the input from the eyes that's going in, but actually it's modified by things like memory. So we have got feed forward, which is what comes in from the eyes, and then we've got feedback, which is things like memory. And that makes our vision super, super quick, so we can react really fast to what's going on around us. Now, when you haven't got the feed forward, the feedback is going to take over. And that's one of the theories of Charles Bonnet syndrome. And that's why you will only ever experience things that are kind of within your cultural experience. So someone in Africa, for example, is never going to see a Victorian figure. And people on this side of the world are never going to see figures that are only pertinent in Africa. So everything that you see in your images you will have had exposure to either directly or indirectly, and are kind of culturally appropriate. And that is evidence that fits in with the whole feed-forward feedback imbalance. And so just having some level of vision loss seems to be enough to trigger that. It doesn't have to be significant. So we can bust that myth right now. The one exception to this rule seems to be cataract. Because cataract is so slow, the brain seems to be able to adapt to that, so you don't get Charles Bonnet syndrome as a result of cataract, interestingly. Myth number 4, CBS only occurs for a short time. So again, when I first studied a couple of decades ago, we were taught that CBS is a temporary thing. And I think that still seems to be taught today, is that you might get it for up to 3 years and then it disappears on its own. And that might be true for the majority of cases, but it definitely isn't true for everybody. So the vast majority of people probably will have CBS for a time, but we don't know whether they have it for a time, it resolves, and then it might come back again, resolves, come back again, or whether it's gone for good. We just don't know. We don't know whether it's more likely to happen at the start of your vision loss journey or later on. We don't know, but we do know that some people have hallucinations for a very long time. I've got some patients who've had them for 14, 15 years and show no sign of abating. So it's very, very variable in different people, how often they have them, how long they have them for. And at the moment, we have no way of predicting that at all. And it's also worth noting that, yes, the hallucinations are very distressing for some people, but for some people, they can actually be pleasurable. I've had patients who report seeing flowers and they really enjoy that. And if you enjoy it, great, enjoy it. And but probably for the vast majority, the hallucinations, once they understand what they are, they're neutral. But I also want to point out that a key diagnostic feature of CBS is that you have insight. You understand the logic that although they look really real, they are not real. And that insight is really key, because if you can't understand that they're not real, that the vision that you normally see in day-to-day life is not clear, that the hallucinations are clear, and that's a key way of telling them apart. And yes, they may seem really real, but you can logic your way into realizing that they're not real. If you can't get that insight, then it's not CBS. Then that warrants further investigation and referral for something else. Further psychiatric referral, basically. So with CBS, you need to have a presence of some kind of visual decline. It doesn't need to be severe. It doesn't need to be extensive, and it doesn't need to be in both eyes, but it needs to be present. And there needs to be insight into the fact that they are not real. So we can bust the myth that they're only there for a short time. So what causes CBS? So I have purposefully haven't put up any images there because I didn't want to overwhelm you. But this is where all the neuroscience work we've been doing has been extremely exciting, because what we've been doing is looking at the brains of people using various imaging types. So thank you to those who have participated in those studies. So first we did an MRI study where we looked at some people who have low vision but don't have hallucinations, and have low vision but do have hallucinations. And we looked at the neurochemistry between the two brains, and we didn't really find a big difference, but we didn't have huge numbers because we did struggle to recruit because of the pandemic. Then we looked at EEG, so that was in Oxford, and then I moved to Cambridge. And then in Cambridge, we recruited some people with frequent hallucinations, and we looked at how the EEG signal, so this involved putting lots of electrodes all around the head, and looking at how the signals change in people with frequent hallucinations before, during, and after the hallucination. And what we found is a change in the signal just before or at the beginning of the hallucination starting. The alpha signal drops over the visual center, which is at the back of the head, and then it comes back to normal at the end of the hallucination. So we knew when people were having a hallucination because they were pressing a button at the beginning and the end of their hallucinations. And they had quite a few hallucinations during the hour we were recording the brain waves. And the alpha waves are associated with a change in vision. So that to us was a signal that there was a change in the visual consciousness that was happening in the brain. So we found basically the brain signal associated with the hallucination using the EEG, which is very exciting. And we found that consistently in all the patients that we saw. So it was a small group of people, but it was consistent in all of them. So now we've got that signal, we can go out to the wider medical community. So not just ophthalmologists and optometrists, we can go out to the whole wider medical community and go, look, this is a real thing. Because if you look at the history of medicine, you know, schizophrenia wasn't believed until they found the brain signal. Chronic fatigue wasn't believed until they found the brain signal. Chronic pain wasn't believed until they found the brain signal. The epilepsy wasn't believed until they found the brain signal. So now we've got that brain signal, we can go to the wider medical community and we can educate them about CBS and say, look, this is a real thing that you need to know about. So when patients come to you and they've got a history of vision loss, or even if they don't, maybe you need to flag it as part of your differential diagnosis and actually take this more seriously. And maybe one of the things you need to flag is go to your optometrist, get your eyes checked, and check whether there is any visual disorders there before you go down the psychiatry route. There's still a lot we need to learn. We need to build on that research, but we really struggle to recruit for these studies. So if we're going to build on that, we're going to need an awful lot more volunteers to come in and do this work. Because without having the volunteers, we're not going to be able to figure out what those signals are and when they appear and what happens to them. So I see some questions are coming in, but I'll take them all at the end because we're nearing the end of the talk. So potential treatments. So far, drugs have been tried in very small scale ways, and they've not been shown to have a high success. And I think a large part of that has been because we didn't know what we were actually treating. So they were non-specific, and also drugs tend to have a lot of side effects. So I don't think drugs are really going to be the right way to go, to be honest. Knowledge, knowing that this is expected and knowing that this is real seems to have a huge positive effect. So the way I see it is, don't let the hallucinations control you, you control the hallucinations. So the first step is talking to your healthcare practitioner, whether that's an optometrist or someone at the hospital. If you suspect you have CBS, please talk to someone the next time you go have your eyes checked, and then they can investigate and advise whether they think it's likely CBS or not. And just having that knowledge base can be hugely helpful, because if it is CBS, you start taking control of your hallucinations. So I think knowledge is going to be the first step and the biggest step going forward. If you find the hallucinations distressing, absolutely get counselling. And try and figure out where in your subconscious that they are coming from. And maybe that might be a good way of trying to change the hallucinations that you're getting. Frequent blinking has been reported by some people. The evidence doesn't seem to be that convincing on a group level, but for some people it seems to be incredibly effective. Some people find just closing their eyes and resting seems to help. whereas for others that makes things worse. Some people find ignoring their hallucinations incredibly helpful. Others find the opposite, interacting with their hallucinations makes them go away. So this is all about taking control, as I was saying earlier. So for some people, ignoring the hallucinations is taking control, because the hallucinations then can't butt in. Whereas for others, like, taking control means interacting with them. So then the hallucinations almost learn that, oh, it's like a little persistent child. Then the child gets the attention and goes away. And there has been a recent study that looked at applying an electrical current through the skull to the visual part of the brain, and that was done in Parkinson's, which has very similar hallucinations to CBS, and that showed good results. But that was a small pilot study, so I think that needs a lot more. Although that showed promise, that needs a lot more investigation before it really becomes authorized as a proper treatment that will become embedded as a mainstay of treatment. But I think now that we know that there's a signal coming from the visual center of the brain, if we're going to go down any route, then maybe that's a way to go, because that is acting direct. But I would say that if we're gonna, I would say that first and foremost, knowledge is the way to go. And someone's in London, there's a group that's doing a really interesting study about a podcast. How much does having a podcast that informs you about CBS and dealing with CBS helps? And then something like transcranial electrical stimulation would be more at the end of the really persistent and maybe more distressing hallucinations. And you probably don't need to go to that end for the day-to-day ones that are less distressing, that can be dealt with the more passive techniques like knowledge and ignoring or interacting with the hallucinations. So that's my 2 cents worth from my 20 years of experience of dealing with patients with CBS. But I'd be interested in hearing people's take from their own strategies of how they've learned to deal with it. And then there is an ongoing study at the moment where we're recruiting people, and this is a way of trying to predict who's going to go on and develop CBS. So we want everyone to answer this questionnaire, whether you've got CBS or not. So there's going to be a link put in the chat. Please spread it with your support groups far and wide. We need as many responses as we can get. So we want everyone, so everyone with low vision, whether you have hallucinations or not, to answer the questionnaire, please. And the whole aim of this study is to see if we can try and predict who's going to go on and develop CBS. And with that, I'm going to stop with my croaky voice and start answering questions.
Thank you very much. Really, really interesting. And I can see we've already got lots of questions coming through. So we'll do our best to cover as many as we can, if that's okay. 2 questions we might link together, because there's a similar sort of theme. So does your experience show it's more prevalent in darkened environments versus light surroundings? And then a linked question maybe is, I only get CBS in the dark or as I awake. Why would that be? I thought it was about missing out on what you should be able to see, but in the dark, you're not meant to see anything.
Yeah, so it's actually really common to have more hallucinations in the lower light level. And when we were doing the EEG study, because we were trying to get people to hallucinate, quite a few people said, oh yeah, I get them more around dusk when it's going dark. So we kept our room lighting low to create conducive environment for people getting their hallucinations. So actually it is really, really common, though it is quite individual as well. So why that is an interesting question. I think it's because signal to noise ratio is altered. So as you get as the light dims in many eye diseases, the information you're getting through is even less than in the light. So as you crank up the light, you're cranking up your visual signal as well. So you're
Yeah,
improving your signal to noise ratio. As you put down the light, your signal, your noise, your signal decreases and your noise increases.
yeah, and that makes sense.
So, so I think it's the brain's way of filling in the bigger gaps that you've now got
Yeah,
and trying to make sense of that noise.
yeah, that makes sense. Um, thank you. This question, I'm not quite sure. There might be a typo in this. So the question is, can vertigo be a cause of macular degeneration? But I'm not sure if they mean a CBS maybe. I've had vertigo for 4 months. I've had a referral to ENT, but have central sight loss in left eye, had injections in right eye. I have glaucoma also.
No, vertigo is related to ears. So
Yeah,
vertigo is very much completely separate. Now, if you've got vertigo because you're causing stress on the visual system, you might increase CBS, pre-existing CBS symptoms
okay,
because of the stress that it induces, but it
yeah,
cannot cause CBS.
thank you. This was a question which was submitted in advance via email. You may have answered some of this in your talk anyway, but just in case you've got anything to add. So someone asking a question on behalf of an elderly neighbour. They have regular visions which have increased in frequency since their husband died nearly 2 years ago, and that's now daily and very upsetting. They see vivid faces of groups of people inside and outside the house. It's becoming such a problem she may not be able to live alone. A really sad story. Will this continue indefinitely? And is there anything that can be done to help? It's been about 18 months since her last ophthalmology appointment.
Oh dear.
Yeah.
Better social support will definitely help because isolation definitely increases hallucination. So I think living alone must be aggravating it,
Yeah.
particularly as that's a new situation. So is there a way of improving the support around this lady, getting her into more social clubs, getting family to visit more often? Um, I think those would all definitely help. Has she definitely got insight into the fact that the hallucinations are not real? Are we sure this is CBS as well
Yeah. Okay.
and
Thank
not some kind of dementia?
you. Yeah. Okay. Thank you. Is CBS hereditary?
No idea.
No, I don't.
Because
Sorry.
we can't predict who's going to get it and who's not. I hand on heart can't answer that.
It's good. It's good to know there are obviously lots of unanswered questions still in science. It's good to acknowledge the ones we don't have an answer to yet. Um, well, I'm going to link these two. So one was, do you see things that you fear? And then there was a similar theme. I deliver ghost walks as a fundraiser for a local charity. Could CBS be responsible for many ghost stories?
Oh, I love that question. Absolutely. I've never thought of that before, but yeah, absolutely. That would
And
make a lot of sense.
so we may have an explanation. And is it common for people to see things that they fear?
Yeah, I think so. So, I mean, for the kids, um, monsters came up quite frequently.
Mm.
And so one of the differentials for that was like how, those often got put down as, oh, kids often have imaginary friends. It was like, well, except imaginary friends tend to be pleasant.
Mm.
So how do you tell the difference? Well, CBS is scary. Monsters are scary. Imaginary friend, you wouldn't create an imaginary friend that's unpleasant. So if it's a monster, it's likely CBS. If it's an imaginary friend, it's probably pleasant. Um, so yeah, some people do see things that are really scary, but not everyone does. And how we don't know why some people see things that are scary and some don't. Um, no idea.
Lots and lots of unanswered questions still.
Yeah, yeah, there really are. It's so understudied. And there are a handful of us, mainly in the UK actually, who are doing quite a bit of work into CBS, but still a lot we don't understand. But interestingly, all of the people that are saying things are talking about complex hallucinations, so like faces and
Yeah,
monsters and things. But not everybody sees complex
yeah,
hallucinations. Some people see simple things, so zigzag lines, colors, um, uh, and sometimes it can be hard to differentiate between CBS and other um, percept. So like there's visual snow syndrome, there's phosphenes, um, there's other things that can appear like spots of lights as well. So sometimes we as practitioners have to tell the difference between CBS and some of these other things as well.
yeah,
So in CBS, you can also get just plain spots of light.
yeah. And
Uh,
there are some questions on that actually. So you must have been reading ahead.
no,
So
not at all. I can't see the chat.
someone said they see colourful squares, not actual recognisable objects. Is that likely to be CBS? They have
Absolutely.
glaucoma and they have some visual field loss and wet AMD controlled by injections with no vision loss.
Yeah, absolutely. That is definitely a form of CBS. So in CBS, you can get all sorts. It's not just complex, what we
Yeah.
call complex hallucinations. You can get just plain colors, simple shapes. So the boxes would definitely be part of that. But
And we got
you don't get sound, you don't get smell, you don't get your other senses involved in
yeah.
CBS. In true CBS, it is vision only.
And there's a few sort of similar questions. If someone has Stargardts and see constantly dimly flashing lights and halo-like whiteout areas that only mildly to moderately interfere with their vision, is that likely to be CBS?
So that's a bit more complicated because that might be phosphenes. So I would they would probably need to speak to their eye care practitioner to differentiate between the two.
Okay.
So it might be CBS or it might
Yeah.
be a combination of CBS and something else.
Okay. Um, so it says their mother has macular degeneration. I've told the doctors many times she sees images. They've noted CBS but do nothing about it. Mum tends to believe the hallucinations because they are so vivid. Um,
If mum believes the hallucinations, can mum be logicked out of believing them? If she can't, it's not CBS. So then you need to start considering dementia or something else. If mum absolutely cannot be logicked out of believing it, it's not CBS.
okay. Um, how common is it to just see patterns? Mine are constant.
Don't know. Don't know. I mean, I do have a few patients who have patterns. Most of the research tends to be done on people with the more complex hallucinations because it tends to be more clear cut.
Yeah. Okay. And do the hallucinations always move?
No.
Okay.
Oh, sorry. Give me 1 second.
Please do keep asking your questions, everyone. You back with us?
Yes, I am.
Yeah, no problem. I have visual. Oh, I think this is about your study. I have visual field loss, but no certification for this. Can I still do the questionnaire?
Yes, absolutely. You don't need certification. You just need to have some kind of vision loss, self-certified. That would be great. Thank you very much.
Thank you.
We need several hundred people to fill it in, so all help appreciated.
Yeah. I think this is a follow-up to one of the previous questions. Yeah, regarding whether it was CBS. So mum has MD and hallucinating. Doctors thought it was CBS. Later, hallucinations started touching mum and talking. Turned out to
That's
be
not
UTI.
CBS.
Yeah, so turned out to be UTI. End result, she now has delirium, still hallucination, so it's complicated. Is she now hallucinating because of her MD? Delirium hallucinations are no longer talking or touching her. Does sound complex, that one.
Yeah, without assessing, I really couldn't say.
Okay, thank you. Um, how can I best help and support lots of family members here? How can I best help and support my mother who sees everything as the colour green, but also sometimes gets pink dots and circles on top of it?
I think just explaining the situation, and just um, just tell her that it's not she's not going crazy and just ignore it. It's just her eyes are playing tricks on her, and can she just ignore it?
Building that understanding can help so much, can't it, with the distress.
Exactly. And
And
it's
it's
not her fault.
no, it's something we hear all the time from our members on, having that understanding and knowing if you knew it was might happen, that would help so much with people, I think.
Yeah.
But sadly, people aren't aware of it until too late. Um, in bright light, usually in green gardens, I see pink, purple bubbles. I look away and forget, and then realise the bubbles have gone. In the middle of the night, I have big black blobs, maybe after sunny days like yesterday and today. Um, no question there, but does that sound like a
Could you
uh,
repeat that, please?
yeah? In bright light, usually in green gardens, I see purple bubbles. I look away and forget, and then realise the bubbles have gone. In the middle of the night, I have big black blobs, maybe after sunny days like yesterday and today.
Do they move, the blobs?
They haven't said. If you're
I would discuss those with your healthcare practitioner, because I actually
okay,
wonder if something's going around, something's happening in the vitreous there from the sound of that.
okay,
So that to me sounds like it could possibly be vitreous floaters.
okay. That's helpful to know. So please do get that checked out, the person who asked that question. Um, my mum has CBS and doesn't drive, but would CBS be a condition which could preclude driving?
No, because you have insight into it, um, shouldn't do. I mean, in most cases, people will CBS won't have vision that meets driving standards anyway.
Yeah,
It's going to be quite rare that you have that you have vision that meets driving standards and CBS, but CBS alone shouldn't do, because you have insight. As long as you can ignore the hallucinations and not let them interfere with your reactions, you should be fine. If they get to a point where the hallucinations are actually interfering with your reactions, then yes, you need to discuss with someone and consider
Yeah.
giving up.
Okay. Thank you. I have moderate to advanced AMD and see faces sometimes, but only when my eyes are closed. What is happening?
That could be CBS as well. So
Okay.
most people have the hallucinations with eyes open, but there are a handful of people that get them with their eyes closed. So I was taught at university that the hallucinations don't happen with eyes closed. But I learnt during the course of recruiting for the EEG study that that's actually not the case, and some people do get them with their eyes closed. So it is absolutely possible to get the hallucinations in that situation.
Okay. Someone says they have quick flashing images of an Apple Watch. I don't have an Apple Watch. Sometimes a watch with the hands spinning around. Why would there be flashing images, not a still picture?
Who knows? The brain
The
works in mysterious ways.
brain works in mysterious ways. That feels like that's the subtitle for tonight's talk, because it certainly does, doesn't it? I'm just seeing if we've got more questions. I think that's covered the questions we've had. The person who was asking about seeing faces sometimes has thanked you for answering their question. A question for me, I guess, what do you think, what might the future look like in terms of treating CBS? What's the kind of dream scenario look like for you?
So my dream scenario is that we are actively screening for CBS all the time, so that we can give people the knowledge and the reassurance um, literally as soon as symptoms occur.
Mm,
Because I think knowledge is so powerful, and that's the step that's missing at the moment. And I think
yeah.
I'm in the minority where I've always actively screened patients and asked them the
Mm,
question since the beginning of my career. And most people don't, and a lot of practitioners are too embarrassed to ask or don't have time to ask. And we need to change that mindset, or they think it's not relevant. Or actually, a lot of practitioners don't even know about CBS, and we need to change that mindset. So, and actually, I've even had patients who have been inappropriately sectioned
mm,
by GPs or psychiatrists because they didn't know about CBS. So
mm,
I feel like we need to educate not only in ophthalmology, but
mm.
across other specialties as well.
Yeah. I think there's a
Particularly with, yeah,
real challenge for us at the Macular Society for the role we can play in that. And, I think
yeah,
talks like this are fantastic, but we clearly need to reach more people. So as you say,
yeah.
everyone, um,
Because we need to educate in nursing homes, we need to educate GPs, we need to educate in probably ENT, because they're quite closely aligned with us,
mm,
and with the rise in dual sensory impairments with an aging population. I think people might talk to them as well as to us. And, we need to think about where else might patients report
yeah,
their symptoms and start educating those professionals.
mm, yeah,
So I think really that for me is the next step.
mm, yeah. And it's really interesting. We've had a lot of people here talking about parents or neighbours. It's clearly, something people are concerned about their family members, so building understanding amongst the general public as well. So
Definitely.
people
Yeah.
can provide that support. We've got a few minutes left, and we've had a few more questions coming in, so I'll just go to those if that's okay.
Yep.
I get static visions of buildings, usually in low light on the periphery of my vision. I've wet M&D controlled by injections. Does that sound like a CBS?
Static images of buildings. Yep,
Yeah,
absolutely. Yep. Like images literally can be anything.
yeah,
So if you can dream it up, it can happen.
yeah. Um, and someone has asked, and it may be the same answer. Watching a concert performance, if the lighting is too poor for me to see the face of the performer, it comes replaced by moving coloured patterns.
Yeah,
CBS.
absolutely. Yeah.
Yeah,
Yep. That
yeah.
absolutely sounds like CBS.
Um, this is an interesting question. Is there any read across between CBS and dreaming?
Yeah, that's a really interesting question. So we did so with my colleagues in Oxford, um we did have a discussion around this because some people are very visual dreamers, and some people are really good at like dreaming in this half wakefulness state,
Mm,
um and some people don't. And so we did think about if there is some relationship there, and could that be a predictor? But then how do you actually examine that? That's the difficulty, is how do you design an experiment to actually test that? And
yeah,
that's where we kind of got stuck
yeah.
in testing that hypothesis.
Mm, very interesting. Thank you. I think we've gone through all the questions which have come in. A few people have been saying thank you for such an informative talk, and it really has been absolutely fascinating. I think all of us have found it really, really useful. Um, we've shared again the link to that study you've mentioned, so please do participate in that. It looks like a really important piece of work, and the more people can participate, the better. Um, Someone has asked if we can put that URL in an email. So, and a colleague has responded already to say we'll add the study link to the next e-news, which is our monthly e-newsletter. So thank you again so much for a really interesting talk. As I say, absolutely fascinating, and I've certainly learned an awful lot.
My
Um,
pleasure.
and we don't have a confirmed speaker yet for our next My Macular and Me. So we'll confirm that as soon as we've agreed. I think we're just waiting for someone to confirm, but that will be on Tuesday, the 15th of July. So at the same time, and whoever it is, I'm sure it'll be another fantastic talk. So I look forward to seeing you all again in a month's time. But thank you again to Dr. Jasleen Jolly. Really interesting talk. And have a lovely evening, everyone. Take care. Bye.